Thank you for the invitation to review our study looking at the effectiveness of first-line immune checkpoint inhibitors in advanced non-clear cell renal cell carcinoma. So regarding some background, so I think as you and a lot of the listeners, viewers are aware, immune checkpoint inhibitors have really revolutionized the treatment of metastatic clear cell renal cell carcinoma based upon the results of multiple large phase 3 clinical trials demonstrating survival benefit to immune checkpoint inhibitor-based therapy in the front line. I think what is less clear is the role of these immune checkpoint inhibitors in non-clear cell renal cell carcinoma. Non-clear cell renal cell carcinoma makes up approximately 15 to 20% of these malignancies. So it's less common than clear cell renal cell carcinoma. And data supporting the efficacy or effectiveness of immune checkpoint inhibitor-based therapies is less clear in this less common renal cell carcinoma subtype. These histologies were largely excluded from the large phase 3 randomized trials that explored the use of these drugs, which, as I mentioned, focused typically on clear cell. The evidence we have to date is largely retrospective, as well as some prospective non-randomized data. And the data that we have to date suggests that these drugs could be active in this space, but there's certainly a paucity of really robust data in terms of randomized data to give us some guidance on the use of immune checkpoint inhibitor-based therapy in non-clear cell renal cell carcinoma. That really formed the basis of our present study, which really the primary aim was to really look at the real-world outcomes or effectiveness of first-line immune checkpoint inhibitor-based therapy in advanced non-clear cell renal cell carcinoma. The aim of the study was to review the real-world outcomes, effectiveness of first-line immune checkpoint inhibitor-based therapy in non-clear cell renal cell carcinoma. And to accomplish this aim, we used the IMDC data set, which I think many of you would be familiar with. It's a large international registry database of metastatic kidney cancer patients, which is led by Dr. Daniel Hang in Calgary and Dr. Tony Chueri in Boston. So using this database, we retrospectively identified patients with non-clear cell renal cell carcinoma, metastatic non-clear cell renal cell carcinoma, and we looked at really all subhistologies of that group, and we basically classified this group into three subgroups based upon the type of first-line therapy received. And this included grouping them into those who received immune checkpoint inhibitor-based therapy. This included monotherapy or combination therapy with either another immune checkpoint inhibitor or a targeted agent. The second group were those who received monotherapy with VEGF targeted therapies. And the third group were patients who received mTOR inhibitor-based therapy. And the outcomes of interest were three. So we looked at the objective response rate by treatment group, time to treatment failure, and as well as overall survival, sort of stratified by these three treatment groups. We use multivariable Cox regression analysis to adjust for important prognostic imbalances between these three groups, which are pre-specified, and included the IMDC risk group, which is a well-validated prognostic score, which has been validated in non-clear cell renal cell carcinoma, and basically, divides patients into one of three prognostic groups. So we controlled for IMDC risk score, we controlled for the actual histologic subtype of the disease, as well as patient age. So in total, we were able to identify just over 1,000, so 1,181 patients with metastatic non-clear cell renal cell carcinoma. Not surprisingly, the majority of these patients received VEGF targeted therapy. About just under 80% received VEGF targeted therapy in the first line. About 15% received mTOR targeted therapy, and in a smaller proportion received immune checkpoint-based therapy at just under 6%. And again, this included either monotherapy with an immune checkpoint inhibitor or in combination, which we've seen being used in the clear cell patient population. So in terms of baseline characteristics, we were able to capture, as I mentioned, histologic subtypes. The majority of the cohort was papillary, which again is not surprising, given that this is the most common subtype of non-clear cell RCC. And then the majority were chromophobe, unclassified, collecting duct, and translocation. We're also able to capture information on IMDC risk group. Again, the majority of patients were in the intermediate risk group. We also have information on sites of metastases, including, whether the patients had liver, bone, brain, as well as specific other histologic features like sarcomatoid histology. So within the three treatment groups, the most common targeted agent was sunitinib, making up about just under 70% of the VEGF targeted therapy group. Within the mTOR therapy group, the most common agent was temsirolimus. And within the immune checkpoint inhibitor therapy group, the most common combination was nivo-ipi, followed by a combination of atezolizumab with bevacizumab, and then followed by monotherapy with nivolumab and pembrolizumab. So again, a mix of different immunotherapy-based treatments. Regarding our outcomes, so we looked at, as I mentioned, overall survival, time to treatment failure, and objective response rate, stratified by treatment group. The median overall survival in the immune checkpoint inhibitor group appeared to be numerically longer than the mTOR or VEGF therapy group. And when controlling for the pre-specified prognostic variables, including IMDC risk group, the histologic subtype, and age, we found that there appeared to be an improvement in survival with immune checkpoint inhibitor-based therapy compared to VEGF or mTOR targeted therapy, with hazard ratios of 0.58 and 0.48 respectively, with p-values that were less than 0.05. Regarding objective response rate, we were able to report the response rate for the entire population, as well as some of the specific subgroups where we had enough patients to report on. In the entire population, the objective response rate was 25% with immunotherapy-based treatment, compared to 17.8% in the VEGF therapy group and 5.8% with first-line mTOR targeted therapy. And then we were able to report on, as I mentioned, specific subgroups within the non-clear cell population, including papillary RCC. And we saw that the response rate to papillary RCC was actually closer to 31%. And interestingly, in the chromophobe subgroup, we actually found that the response rate to immune checkpoint inhibitor-based therapy was actually lower at 9.1%, and that in this specific subgroup, the response rate to VEGF targeted therapy was 20.6% and mTOR 13.6%. So, in summary, what we attempted to accomplish was to describe the real-world outcomes of immunotherapy in the first-line treatment of advanced non-clear cell RCC. Based on this retrospective data, we were able to show that there was an association between immunotherapy in the first-line setting and improved outcomes, including survival, even after adjusting for prognostic imbalances such as the IMDC risk group and histologic subtype and age. And interestingly, our response rates were consistent with existing literature in this space, including prior retrospective studies and some of the single-arm prospective results. I think some of the interesting findings included the differences within the subgroups, including the lower response rate in the chromophobe subgroup, which has been previously reported to be a more of a in terms of more of a less likely to respond to immunotherapy, so an immunologically cold tumor. And our results seem to support that. I think these results really need to be interpreted with caution, given some of the inherent limitations of this kind of analysis, such as that this was retrospective. There certainly could be unmeasured confounding variables that could explain this association, as well as bias, as well as a heterogeneous population. I think one of the most important takeaways is that, although these findings suggest immune checkpoint inhibitors have activity in the space, that these results really need to be confirmed in prospective randomized trials.